Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 5 of the cardiology chapter. We're going to start by talking about pressure in the cardiovascular system. Pressures in the heart can be measured with a pulmonary artery catheter and can provide information about the clinical status of a patient. Right atrial pressure is equal to central venous pressure because the central veins, the superior and inferior vena cava, feed the right atrium. This is a low pressure area because the veins are low pressure vessels. Right atrial pressure will be increased when there's too much volume in the veins or difficulty feeding that volume to the heart, such as in right ventricular failure, when the ventricle cannot pump the blood given to it. Right ventricular pressure is normally lower than left ventricular pressure because the pulmonary circulation is normally a lower pressure circuit than the systemic circulation. Right ventricular pressure can increase if it is pushing against a higher pressure afterload, such as in pulmonic stenosis or pulmonary hypertension. As the right heart has lower pressures than the left, atrial or ventricular septal defects will result in a shunt, at least initially. We'll talk about Eisenmenger syndrome in a moment. This occurs from left heart to right heart, high pressure to low pressure. The pulmonary artery pressure can be increased in pulmonary hypertension from lung disease or pulmonary vessel disease such as pulmonary embolism, or it can occur from left heart failure because the fluid will back up into the lungs if the left ventricle cannot pump it out. The pulmonary capillary wedge pressure is our way of measuring left atrial pressure because the catheter cannot fit through the small capillary beds of the lungs. This can be increased if the left atrial pressure is high, such as in left-sided heart failure, but also in problems with the mitral valve. Stenosis, because the left atrium cannot empty. Regurgitation, because blood will be forced back into the atrium from the ventricle. In cardiac tamponade, which we'll cover in depth later, the heart is being essentially strangled by fluid that is trapped in the pericardial sac. This leads to equalization of pressure across all four chambers. The high pressure exerted on the heart is from all sides because the pericardium surrounds the heart. This is rapidly fatal if not corrected. An electrocardiogram, or ECG, is a useful tool to assess the electrical activity of the heart. When the cardiac myocytes go from polarized, resting state, to depolarized from an action potential, an electrical current is generated that can be measured. The USMLE Step 1 will only test ECG basics, but it is worth your while to invest time in reading an ECG book to gain a deeper understanding after you're done crushing Step 1. The P wave represents atrial depolarization. After the P wave, there is a PR segment. This is the conduction delay at the atrioventricular node, which allows the ventricles time to fill fully before contraction. It is normally 0.12 to 0.20 seconds. Therefore, diseases of the atrioventricular node often manifest as PR segment prolongation or abnormalities. The QRS complex represents ventricular depolarization. The terminology of the QRS complex can be difficult, but basically, if the first deflection is downward, it is a Q wave. If the first deflection is upward, a Q wave is not present. The first upward reflection is always an R wave. Any downward deflection after the R wave is known as an S wave. The atria repolarize during the QRS complex, but do not make a tracing because the ventricles have many more myocytes and dominate the ECG. Normally, the QRS duration is less than 0.12 seconds. But if the fast His-Purkinje conduction system is malfunctioning, then the QRS complex becomes abnormally widened, such as in bundle branch blocks. The T wave. After the ventricles depolarize during the QRS complex, there is a brief delay, the ST segment, followed by repolarization, which is the T wave. There is sometimes a U wave that follows the T wave, which can be normal, but is not a common finding. It may also be seen in conditions such as hypokalemia or bradycardia. An ECG printout has two main components, the 12-lead ECG, which looks at the heart from different vectors or angles, and the rhythm strip, which is useful for noting abnormalities in the rhythm or rate. Basic rhythm strip abnormalities will be presented and explained. It is important to be able to assess the heart rate. Each little box on the ECG strip is 0.04 seconds or 40 milliseconds, and each big box is made up of 5 little boxes and is therefore 0.20 seconds. To assess the heart rate, count the number of big boxes between QRS complexes, and then remember 300, 150, 100, 75, 60, 50. If there is one big box between beats, the rate is 300, 2 is 150, and so forth. Now let's talk about normal sinus rhythm. To be classified as sinus, a P wave, or atrial contraction, must precede every QRS complex, denoting that the atria are conducting the impulse that was generated by the sinoatrial node through the AV node. In addition, it is normal because there is neither bradycardia nor tachycardia present. The heart rate is between 60 and 100. Sinus tachycardia. The ECG is sinus because there are P waves before each QRS complex. But using the big box method and looking at figure 16, we see that the heart rate is 150. Therefore, it is sinus tachycardia. Now let's talk about atrial flutter, and we'll look at figure 17. In atrial flutter, there is an abnormal reentry of electrical activity around the tricuspid valve annulus, causing a self-sustaining loop of activity. This usually occurs at an atrial rate of 300, which is too fast for the AV node to conduct to the ventricles. Most commonly, the impulses have a 2-to-1 conduction block, meaning the ventricular rate is about 150 if the atrial rate is 300, because only half of the impulses are conducted. Patients with atrial flutter most commonly have some form of structural heart disease. The flutter waves in the image in figure 17 are denoted with an F and often have a sawtooth appearance, and each wave should be nearly identical. Now let's talk about atrial fibrillation. In atrial fibrillation, there's random activation of the atria that is unpredictable and chaotic, leading to no discernible P waves because there is no coordinated depolarization. The impulses that are transmitted through the AV node to the ventricles occur without a pattern, leading to an irregular rhythm. This is in contrast to a regularly irregular rhythm in which the irregularity is predictable and occurs at regular intervals. For example, an irregular beat every 5th beat, which can occur with atrioventricular blocks. This is the most common chronic arrhythmia and can be dangerous because without a coordinated atrial contraction, stasis of blood can occur with resulting clot formation, potentially leading to strokes if the thrombi occur in the left atrium, with embolization of clots to the brain. Therefore, these patients require anticoagulation with either aspirin or warfarin or a direct-acting oral anticoagulant such as dabigatran, depending on the risk factors. Now let's talk about ventricular tachycardia. In ventricular tachycardia, there is an abnormality in the patient's ventricles, often an old scar from a myocardial infarction, that causes abnormal conduction and a reentry circuit in the ventricle, leading to rhythmic depolarization of the ventricles. Treatment is to reset the heart to normal sinus rhythm, which in the stable patient can be done either chemically, for example with procainamide or amiodarone, or electrically with cardioversion. Patients with ventricular tachycardia without a pulse should receive cardiopulmonary resuscitation and early defibrillation. Now let's talk about torsade de pointe. This is French for twisting of the points. Torsade de pointe is a specific type of polymorphic ventricular tachycardia, in contrast to the previous example of ventricular tachycardia, where each beat looked the same and was therefore monomorphic. Anything that prolongs the QT interval makes this more likely to occur, such as congenital long QT syndromes, hypocalcemia, hypomagnesemia, hypokalemia, or medications that prolong the QT interval. In fact, treatment of torsade de pointe includes rapid intravenous infusion of magnesium. Medications associated with increased QT interval include certain antibiotics, antiarrhythmics, antipsychotics, antidepressants, and antiemetics. Now let's talk about ventricular fibrillation. This disordered and rapid depolarization of the ventricles causes cardiac output to drop to essentially zero, making this rhythm life-threatening and rapidly fatal if untreated. CPR and defibrillation in a rapid manner are life-saving. Now let's talk about WolffParkinsonWhite Syndrome. Also known as ventricular pre-excitation syndrome, WPW syndrome is caused by an accessory pathway known as the bundle of Kent between the atria and ventricles. Normally, the AV node is the only passageway for electrical conduction. These patients have an extra pathway. This extra pathway causes the ventricles to begin depolarizing before they normally would, leading to a premature upsloping in the QRS complex known as a delta wave. Because now there are two routes to transmit impulses through the ventricle, it is possible to have a re-entry circuit in which an electrical impulse can travel in a circuitous path in one of two directions. One, orthodromic, meaning that the signal travels antegrade down the AV node as normal, but then retrograde through the bundle of Kent. Second is antidromic, meaning the signal travels antegrade through the bundle of Kent and then retrograde through the AV node. Orthodromic tachycardias generally have normal appearing QRS complexes, as electrical signal travels normally down bundles of His, while antidromic tachycardias are characterized by widened QRS complexes. Now let's talk about regulation of blood pressure. Regulation of blood pressure occurs with two main mechanisms. First, the baroreceptor reflex, and two, the renin-angiotensin-aldosterone axis. The baroreceptor reflexes uses pressure sensors in both the aortic arch and the carotid body to monitor blood pressure and modulate parasympathetic and sympathetic tone accordingly. These baroreceptors are constantly sending signals to the brainstem, but the rate of these signals will change with the pressure exerted on their receptors. With an increase in blood pressure, the rate of these parasympathetic signals will increase. With a decrease in blood pressure, the rate will decrease in an effort to normalize the blood pressure disturbance. The carotid sinus baroreceptors send their information to the brainstem using the glossopharyngeal nerve, cranial nerve 9, whereas the aortic arch baroreceptors use the vagus nerve, cranial nerve 10, as their afferent nerve. An increase in blood pressure causes more stretch on the pressure sensors because the arteries have more pressure to exert on the arterial wall. This causes the baroreceptors to enact changes that will decrease blood pressure. The increased stretch leads to increased firing of the baroreceptors, which 1. Increase parasympathetic tone through the vagus nerve on the sinoatrial node to decrease heart rate, and 2. Decrease sympathetic tone. A decrease in blood pressure causes less stretch on the pressure sensors because the arteries have less pressure to exert on the arterial wall. This causes the baroreceptors to enact changes that will increase the blood pressure. The decreased stretch causes decreased firing of the baroreceptors. This, in turn, causes 1. Decreased vagal tone to the sinoatrial node, resulting in an increased heart rate, as well as 2. An increased sympathetic tone to increase heart rate, contractility, and vasoconstriction. This helps mediate the body's response to acute decreases in blood pressure, such as what occurs during hemorrhage. Carotid sinus massage puts pressure on the baroreceptors in the carotid body, leading to the body thinking there is high blood pressure, causing increased parasympathetic tone, as well as decreased sympathetic tone, and therefore a decrease in heart rate. This was previously proposed as a treatment for supraventricular tachycardia, but is falling out of favor owing to risk for inducing embolic stroke by massaging cholesterol-laden carotid arteries. Similarly, Valsalva maneuver can also increase vagal tone and is a non-invasive treatment for supraventricular tachycardia without risk of embolic stroke. The renin-angiotensin-aldosterone axis is explained in detail in Chapter 9, but briefly, the juxtaglomerular cells of the kidney also sense blood pressure. Any decrease in blood flow to the kidney will cause the juxtaglomerular cells to secrete the enzyme renin into the bloodstream. The bloodstream always has angiotensinogen in it, and renin cleaves this angiotensinogen into angiotensin 1. Angiotensin 1 gets cleaved into angiotensin 2 by angiotensin-converting enzyme, or ACE, which an ACE inhibitor blocks. Angiotensin 2 is a potent vasoconstrictor, increasing SVR and therefore blood pressure, and also mediates aldosterone release from the zona glomerulosa of the adrenal gland. Aldosterone increases sodium reuptake from the kidney, leading to an expansion in blood volume and thus an increase in blood pressure. That's the end of this section. In the next, we will begin with pathology.